So what's the truth about prostate cancer treatments? Are they supported by irrefutable and reproducible data for saving significant numbers of lives? Or are they supported mostly by hollow claims? Welcome to HEALTHdrum. I'm Dr. Bert Vorstman, a urological surgeon and former researcher, and this channel is all about sorting out medical fact from medical fiction. By the way, HEALTHdrum provides material for educational and informational purposes only and is not a substitute for professional medical advice. The links to the disclaimer and the material in this video are in the description below. And if you like to get fact-based healthcare information, please hit the subscribe button. Okay, so let's get into it. When you get a prostate cancer diagnosis, you feel absolutely shocked, uninformed, and very vulnerable. You're desperate for truth and science, but are you going to get that? So is the prostate cancer narrative grounded in scientific truth, or is it, like most healthcare recommendations, deeply flawed? Most healthcare information and recommendations are deeply flawed for the following reasons. Healthcare is financially driven. Most published medical research studies are false. Only about 11% of medical treatments are of known benefit. Yet just about everything in healthcare is labeled as standard of care. Also very worrisome, the recommendations you get to manage your particular prostate cancer can vary between physicians and between specialties. For example, there are differences of opinions between surgeons, oncologists, and radiation specialists. Not only are these different recommendations unsettling, but they're very confusing. The bottom line behind all of this confusing information is that recommendations lack irrefutable and reproducible data. So let's drill down on prostate cancers. The cancer label is used interchangeably as if all cancers are equal. But are all prostate cancers equal and dangerous or not? So the term prostate cancer is commonly used interchangeably as if all prostate cancers are equal. In fact, prostate cancers are all very different. Most prostate cancers grow sluggishly, taking some 40 years from the time of mutation to reach about 1 centimeter or half an inch in growth. Most prostate cancers are outlived without any treatment. The Gleason 6 is a pseudocancer, and some 10 to 15% of prostate cancers are high grade and potentially dangerous. So, prostate cancer is a spectrum of diseases, and many of these cancers can be simply monitored. So let's digress for a second here. Many physicians will have you undertake strategies to manage your expectations. Now, why should that be necessary? So prostate cancer treatments are associated with many potentially debilitating complications. In fact, prostate cancer surgery may be associated with more complications than any other type of surgery. And because surgeons are well aware of this, they will try to manage patient expectations before treatment. Physicians will discuss so-called standard of care treatment options and compare one with another. They will have discussions on preferences and risk tolerances and get you to sign a detailed informed consent. Then commonly, they will have you undertake preoperative counseling and postoperative rehabilitation strategies, programs that can help patients be more accepting of likely erection and leaking complications. So let's look at treatment options for localized prostate cancer. There are several whole gland treatments and there are several focal therapy options. The word options is clearly confusing and has you wondering why nobody has found the secret sauce for treating localized prostate cancer. So this is a screenshot of the current treatment options for localized prostate cancer and includes surgical, open or robotic assisted, radiation with or without androgen deprivation therapy or testosterone suppression, brachytherapy or seeds, proton beam, and then focal therapy using cryoablation or freezing, high-intensity focused ultrasound or HIFU, laser, and photodynamic therapy or PDT. Remember, all of these options are considered standard of care. The fact that all of these treatment options exist for prostate cancer is concerning and have you wondering which one has the best track record and where can we find the irrefutable and reproducible data supporting these treatments as being safe and life-saving. So let's see how open prostate cancer surgery originated and how it morphed into being standard of care without any scientific testing for safety or life-saving benefits. So here are some details about how open surgery for prostate cancer developed in the early 1900s as a perineal or behind the scrotum approach. This approach had been done since ancient times for bladder stone removal. Dr. Young claimed early diagnosis and radical cure of cancer, but this was a barefaced lie as there was zero evidence for early diagnosis and for radical cure. He also described the procedure as providing satisfactory functional results, which was also a lie as 2 patients died and 2 were left with lifelong incontinence after prolonged hospital stays. Over time, because of rectal injuries occurring during the removal of the prostate by this method, other surgeons adopted alternative approaches to the prostate, such as from above and behind the pubic bone or retropubic approach. Although this retropubic approach was now accepted practice, the urinary leakage and erection complications remained distressingly high. Despite the many ongoing complications, however, radical open surgery for prostate cancer became an accepted practice, then standard practice, and then morphed into standard of care without any scientific evidence for safety or benefits. So what about robotic-assisted prostatectomy? How did that enter the prostate cancer treatment landscape? And was that ever scientifically tested for safety and life-saving benefits? So robotic surgery's origins are directly linked to the desire to improve battlefield treatments. And to bring it mainstream, the device makers tested the robotic device for robotic-assisted gallbladder surgery in Mexico. In Mexico, there are less regulatory hurdles. And a study was done comparing laparoscopic gallbladder surgery to robotic-assisted gallbladder surgery. The study provided no clear benefits, but despite that, robotic-assisted gallbladder surgery was FDA approved. But although FDA approved, the device makers quickly discovered that there was no market for robotic-assisted gallbladder removal as the laparoscopic approach was easier. This result forced the device maker to look for other procedures where the robotic device could be used. Eventually, the device makers discovered that urologists were struggling with the laparoscopic approach to prostate cancer surgery, and they were keen to try the robotic device. After some experimentation, the device proved useful for radical prostatectomy. However, instead of proving scientifically with irrefutable and reproducible data that the robotic-assisted prostatectomy was safe and life-saving, the device maker was able to get the robotic device FDA approved for robotic-assisted prostatectomy by a sham 510K maneuver without any scientific testing for safety or benefits. Unsurprisingly, the FDA's MORD, or Manufacturer and User Facility Device Experience Program, recorded a big uptick in adverse events associated with robotic prostatectomy. What about the other treatment options like radiation and focal therapy? Are they scientifically proven to be safe and life-saving? So as well as the open and robotic prostatectomy options, there are radiation and focal therapy options. These include external beam radiation, brachytherapy or seeds, proton beam, focal therapy using cryoablation or freezing, laser, high-intensity focused ultrasound or HIFU, and photodynamic therapy or PDT. However, like open and robotic prostate cancer surgery, there is no irrefutable and reproducible evidence that these treatment options are safe and life-saving. Now, most marketing claims about prostate cancer treatment options suggest that they are safe and effective. But how safe are they really? So both open and robotic-assisted prostate cancer surgery are associated with many significant, potentially debilitating complications. Let's start with two very important complications. First, some 11 to 48% of men have positive margins or residual cancer. And second, some 20 to 50% of men will have a biochemical recurrence or rising PSA within 10 years after surgery. Right off the bat, you can see that these two important problems underscore the fact that surgery is a bad treatment option because it has a high failure rate. As well, there are a variety of general complications such as rectal tears, hematomas, DVTs, and so on. And then there's a whole list of penile and sexual complications, as well as bladder, urethral, and urinary incontinence complications. Also, many of these treatments will be marketed as being effective. The word effective doesn't mean that they are complication-free, and it certainly doesn't mean that they are curative or life-saving. So clearly, both open and robotic-assisted prostate cancer surgery treatment options are associated with many potential complications. What about the potential complications after radiation or focal therapy treatments? So both radiation and focal treatments for localized prostate cancer are associated with several potential complications. Again, some 20 to 50% of men will have a biochemical recurrence or rising PSA within 10 years of treatment. Many of these men will have negative prostate biopsies despite the rising PSA. Again, the high rate of biochemical recurrence underscores the fact that this treatment is a failure. Radiation is also associated with other complications such as burn injuries to the rectum and bladder. Rectourethral fistulas are possible with focal therapy. Bladder and bowel control issues, urgency and incontinence, and erectile dysfunction are other major concerns. As well, there's a small risk of second cancers after radiation treatment, and cancer recurrences are not uncommon after focal therapy. You can get a lot more information on prostate cancer from my other videos. So physicians seem to imply that complications are possible but unlikely. Now, is that true? So this screenshot suggests that treatment complications are more common than physicians would like to admit to. As we have already detailed, physicians are clearly concerned about treatment complications because they have instituted various preoperative and postoperative strategies to manage patient expectations about possible complications. We've already discussed the high rate of positive margins after surgery and the high rates of biochemical recurrence or rising PSAs, which means there are cancer cells somewhere. Physicians are also good at creating self-serving definitions of success, such as labeling you as dry in their studies if you use one pad or less per day. This makes their study results look better, but clearly, if you use any pads, you would consider yourself wet. As well, patients are commonly impacted by more than one complication, and in my experience, patients' partners are usually more truthful about post-treatment complications than the patients themselves. Most men have too much pride to admit to their wetting or erection problems. In my practice, I also found that if I asked the wife or partner the same question about whether they had leakage or erection problems, I'd get a completely different answer from the one that the patient gave me. Unsurprisingly, about 20% of patients will regret their treatment. As well as the impact on the patient, these complications indirectly impact the wife or partner in terms of quality of life, extra costs, and time wasting with medical visits. So how are these complications after prostate cancer treatments dealt with? So the positive margin or residual cancer after surgery is often treated with radiation. Although surgeons denigrate radiation as a treatment option, they are quick to recommend radiation for positive margins. A biochemical recurrence after surgery or radiation is frequently monitored, and then at a certain PSA level, testosterone suppression or ADT is initiated. Bladder leakage and control issues are treated with pads, clamps, catheters, pelvic floor exercises, biofeedback, medications, bulking injections, slings, and sphincter implants. Sexual dysfunction is treated with medications, suction or vibration devices, shockwave therapy, penile injections, or penile implants. And many complications are not fixed or fixed incompletely after the first go-around and will require a retreatment or an alternative treatment to solve the problem. So here's a very uncomfortable question about prostate cancer treatments. Where is the irrefutable and reproducible scientific data that these treatments are safe and life-saving? So this is the most critical question. Do prostate cancer treatments save significant numbers of lives? Amazingly, physicians' own studies have determined that at about 20 years, patients that had no treatment had similar survival rates to those that had radical treatments. However, those patients that had no treatments didn't have all the complications that are normally associated with radical treatments. As well, the lack of curative benefits for prostate cancer treatments makes a mockery of the guidelines for localized prostate cancer, informed consent, standard of care, and the biggest circus of all, prostate cancer awareness programs. Prostate cancer awareness programs, or Blue September, is a circus based on fear-mongering, falsehoods, and shameless exaggerations designed to push men into testing and treatments where there is no scientific evidence that they save significant numbers of lives. Remember, the references to this material are in the description below. So what's the reason some men can have a semblance of cure or appear to be a survivor only to have metastatic disease years later? So here's a screenshot listing some reasons why many prostate cancer treatments lead only to a semblance of cure, particularly for high-grade prostate cancer. Some of these cancer cells can already be metastatic when the cancer is barely detectable in the prostate. This information comes from bone marrow aspiration studies, which have identified disseminated cancer cells lying dormant in the bone marrow. These cells can lie dormant in the bone marrow for years or decades before they are activated and metastasize. This means that patients can have a semblance of cure or being a so-called survivor and only develop metastatic disease years later. At present, there's no irrefutable and reproducible evidence that high-grade prostate cancer can be cured with the current treatments. So is the current prostate cancer narrative about early detection and early treatment mostly fact or mostly fiction? So let's review some facts. Prostate cancer awareness and the so-called benefits of early prostate cancer detection and treatment are mostly a hoax and unproven. Urinary and sexual symptoms are not early warning signs of prostate cancer, but merely signs of aging. Both the PSA test and the prostate exam are highly unreliable. Additionally, the specific label in the PSA test or prostate-specific antigen is a barefaced lie, as the test is not specific for prostate cancer, and the test has a false positive rate of about 78%. As well, urologists' own studies have concluded that PSA testing fails to save significant numbers of lives. Also, the Gleason 6 is a pseudocancer, and neither open or robotic-assisted prostatectomy were ever scientifically tested for safety or life-saving benefits. And survival at about 20 years was similar for those that had no treatment and those that had radical treatments. So how is it possible that prostate cancer treatments can bypass testing for irrefutable and reproducible data and simply morph into being standard of care? Where is the regulatory oversight? So this screenshot lists some of the reasons why prostate cancer treatments were able to bypass testing for irrefutable and reproducible data and magically become standard of care. Fundamentally, it was due to two big factors: junk science and ethical neglect. Physicians themselves produced clinical studies that weren't based on sound scientific principles, but junk science. Physicians also became disconnected from their Hippocratic oath and the creed to keep patients from harm and injustice. As well, regulatory agencies abdicated their responsibilities of oversight, and the AMA failed in true public advocacy. Sadly, this trove of ethical negligence led to a squandering of untold amounts of precious healthcare dollars. The bottom line here is that there was a total lack of accountability in the prostate cancer arena. So what's the best way forward for prostate cancer testing and treatment? How can we make it trustworthy? So what do we need to do to make testing and treatment for prostate cancer safe and beneficial? We need to ensure that studies are based on sound scientific principles and deliver only accurate, irrefutable, and reproducible data. For example, a common, grossly unscientific, risky, and unreliable test is the prostate needle biopsy, which samples by hit or miss only about 0.1% of the prostate. Incredibly, physicians are managing your disease based upon a 0.1% sampling of the prostate. As well, physicians need to reconnect with the Hippocratic Oath for keeping patients from harm and injustice, and regulatory agencies need to return to rigorous testing and oversight. Furthermore, test makers should not be allowed to provide financial incentives to the urology community to market an unreliable product. As well, since PSA testing and robotic-assisted prostatectomy fail to save significant numbers of lives, their FDA approvals should be rescinded. And because of the many problems detailed in this video, the current prostate cancer narrative is nothing but a public health disaster. Again, I have many other videos detailing the various concerns about prostate cancer testing and treatment, as well as various blogs on LinkedIn, Substack, and Medium that you can look into. So what should you do if you get a prostate cancer diagnosis? So here are some things that you should consider when getting a prostate cancer diagnosis. Get opinions from other doctors who aren't financially invested in treatment. Understand your specific case in terms of Gleason grades, scores, and the accuracy of diagnosis. Consider active surveillance. Ask very tough questions. What is the irrefutable and reproducible evidence that this test or treatment will help me live longer? Weigh quality of life issues. Is the potential benefit of treatment worth the risk of permanent complications? To find answers to these questions, you need to do lots and lots of homework. Your research is far more important than any emergency so-called treatment. Also, be very wary of prostate cancer awareness campaigns or Blue September. These marketing strategies are fear-driven and promote exaggerated risks, benefits, and inflated promises. Here also, again, the PSA test is highly unreliable. It's not specific for prostate cancer, and has about a 78% false positive rate, and the prostate exam is equally unreliable. There is no evidence that these programs save significant numbers of lives. If anything, these programs commonly lead men to health dangers. So let's recap. In this video, what is the truth about prostate cancer treatments? You learned that there are many treatment options. Many of these options morphed from accepted practice into standard of care. And standard of care does not mean that treatments are supported by irrefutable and reproducible data for saving significant numbers of lives. To learn more about routine medical conditions, self-care, and digital health, check out these other videos. And if you like them, please share them with your friends.